Welcome. Thank you for being here. In this video, we're going to talk about osteoarthritis in relation to exercise. Now, osteoarthritis is one form of arthritis. It's the most common form of arthritis, and it's the type of arthritis that is being referred to when people say, use the word arthritis colloquially, or with regard to the sort of arthritis that comes on with age. With regard to this relationship between exercise and osteoarthritis, there has been a rather large change in how the condition is viewed, sort of like from a worldview perspective, with the historical view, in my opinion, doing more harm than good to people, and the new view being seemingly more true and much more empowering. So the purpose of this video is to explain what that relationship is, as well as give you some sort of practical tactics to use based off of this understanding. So as always, here's the plan for the video. We'll talk about what those changes are that I've referred to in the first part of this video. We'll then go into a few forms of exercise that are probably the most commonly formed or commonly used forms of structured exercise that people are going to engage in an effort to sort of make this as broad and applicable to as many people as possible. Now, that said, there is a general understanding that I'm going to try to put forth with regard to exercise in general that's going to apply to other forms of exercise as well. So it's not just these three that are really being covered today. We'll then talk about using exercise to reduce your risk of developing osteoarthritis, and then exercising with currently existing osteoarthritis, because those are two different sort of angles to approach the problem from. And then again, this video is not medical advice. This is for information only. And all of the references that I am using to support the information that I'm providing to you can be found in the description box below. So from a very general bird's eye view, osteoarthritis is a sort of degeneration of a joint. So when you have two bones, let's say your femur, your thigh bone, and your tibia, your shin bone, they're kind of coming together like this. On each surface, on the surfaces from which are touching the other bone, there is something called articulating cartilage. And in states of osteoarthritis, that cartilage is sort of worn away. Therefore, the underlying bone is making direct contact with the other bone it seeks to form a joint with. There's usually some decrease in the amount of space within that joint, the amount of space between those two bones that seek to form a joint together. And then ultimately, that bone just undergoes much more degeneration and damage over time. Now, of course, overall, it is significantly more complicated than that, but for the purposes of what we're talking about today, that sort of general description will suffice. The historical view of this condition is that it is a purely mechanical, a biomechanical problem, and it is purely a local problem. So, with regard to knee osteoarthritis, it is a problem, a biomechanical problem of the knee. That's what the sort of historical view would say about this condition. And the term wear and tear essentially comes from the idea of likening the body to a car. If your tires are going to wear out, they're typically not going to wear out in a symmetrical pattern. Usually like the front right tire, for example, is going to wear out more than the others, and that's going to be the one that needs to be replaced first. And with osteoarthritis, typically it's not symmetrical across the body. It's not like you're going to have an equal presentation of osteoarthritis in both knees. You might have it in both knees, but one knee might be worse than the other. And when you look at an x-ray of a joint that has significant osteoarthritis, it does, for the most part, look like it is worn away. The problem with this purely biomechanical view of osteoarthritis is that it ignores the sort of dynamic, adaptive nature of the organism at large, which is you. Now, cartilage, bone, and everything else that makes up a joint is living tissue that is, for the most part, capable of adaptation. The same is not true for a car, which is really the biggest problem I have with that phrase, is that the fact that you are a living thing is a massive compounding variable to make that an appropriate analogy to use here. The current understanding that seems to be more appropriate of osteoarthritis is that it is a metabolic, more systemic problem that has a local presentation. So for instance, there is some sort of systemic pathology of sorts going on. That could be elevated blood glucose, that could be elevated lipids. It's most usually obesity. And then the osteoarthritis is not necessarily a side effect or an effect, but it's a local presentation of that systemic problem. So in practice, there's a few instances through which this tends to pan out. So for one, all of the drugs that have been developed that seek to sort of specifically target the specific problems that are happening in the joint during an osteoarthritis development tend to have very uneventful outcomes. Like they don't tend to work very well. However, things like metformin, liraglutide, which is one of the GLP-1 agonist drugs, these type of medications that seek to treat a more general systemic metabolic problem tend to produce quite favorable results in the treatment of osteoarthritis. They either slow down the progression of it, they tone down the symptoms, they make it better one way or another. Nutrition can also provide a decently good example of this sort of relationship, in the sense that sufficient fiber intakes have nothing to do with any one joint in particular. It's just something that's good for your general overall systemic metabolic health, tend to reduce your risk significantly of developing osteoarthritis. And in people who have osteoarthritis, it seems to lessen symptoms and slow down the progression of the condition. And finally, with regard to exercise, which obviously we're going to cover in a bit more detail throughout the rest of this video, exercises and exercise programs that treat the joint itself, like giving hip exercises to a hip osteoarthritis condition, tend to not do nearly as well as an exercise program that just seeks to improve a person's overall health or fitness rather, because that in turn improves the overall functioning of the body at large. Now, it's worth noting that osteoarthritis is somewhat ingrained into the aging process. So, for instance, if we were somehow able to get so good at lifestyle intervention that we were all living to 150 to 200 years of age, we'd probably all need joint replacements at the age of 120, 130 or something like that, no matter how much you crush everything else. But how symptomatic it is, how early on it sets on, and how quickly it progresses is very much in your control. So a better way to use the car analogy that's often used with this sort of thing would be as follows. Let's say you bought 2 cars today. One you never got an oil change for, and one you very up to date with your oil changes on. The car that you never get the oil changes on is eventually going to sort of break down and wear and tear out significantly sooner than the car with which you are up to date with your oil changes on. In this regard, the problem is less the wear and tear itself and more the fact that the car just wasn't taken care of. So there's this database called the Osteoarthritis Initiative, which is essentially a large database of patients who have or had osteoarthritis, and a lot of their behaviors and features and factors about them were tracked for the purpose of figuring out what helps, what doesn't help, etc. There was a retrospective cross-sectional study published in 2024, which that just means it's a group of people in which they were looking back in time and seeing how certain variables affected the progression of the condition. And the researchers classified osteoarthritis into radiographic versus symptomatic. So radiographic means the osteoarthritis you would see on an x-ray, what the actual picture would show. And symptomatic is what the person actually experiences. And it's important to note that these are differentiated because the two are not always the same. You can have a progression of your radiographic osteoarthritis, like your x-ray might look worse, but your symptoms are no different. You can have an improvement in your symptoms, but your x-ray looks no better. Or, sometimes you can even have a worsening of your x-ray, but an improvement of your symptoms. That's a bit more rare. They do tend to somewhat track, but they are different nonetheless. For instance, when you talk to people who have been struggling with osteoarthritis, something they'll say is that there are good days and there are bad days. But it's not like if you x-rayed their joints on the good days versus the bad days, you're going to see a markedly different picture. You're going to see the same thing, but their presentation, what they feel, is going to be different some days versus other days. So these researchers, they classified cycling participation by viewing it in terms of cycling at different stages of their life. So they bracketed 4 different life stages, which can be found right here on screen. And if you're only listening to this, it's 12 to 18, 19 to 34, 35 to 49, and then above 50. And you are classified as a cycler if you performed cycling, and this could be stationary road, anything where you're cycling, any kind of cycling, if you cycled on more days of the week than not. So for those who didn't cycle more days a week than not, those would be classified as non-cyclers because it's not something that was typically integral to their daily routine. And then there was different doses depending on how much the person cycled, which forgive me is forgetting or is escaping me. But the bottom line, because overall of the paper, was that the more cycling a person did in terms of high versus low, more life stages versus not life stages, the more cycling they did, the less risk of osteoarthritis, both radiographic and symptomatic. Now, this differs from the effect that running is going to have on osteoarthritis, and we'll talk about that in just a second. But really, in my opinion, the reason why this is that cycling, because it is, for the most part, low range of motion and low impact, you can sustain a lot of it and not really have a very high recovery demand or, high level of fatigue that accumulates. So for that reason, it's really hard to hit a dosage of cycling that's really going to cause you problems per se. Furthermore, improving your aerobic cardiovascular fitness is probably the single most health promoting thing you can possibly do from a general systemic standpoint. And again, the person's general fitness and aerobic health improves, ergo the adaptability of each individual joint and the resilience to degeneration, such as with osteoarthritis, is also improved. So if I had to say why more cycling equaled less osteoarthritis, That is what I would say. Like I said, running does seem to be a little bit different. So the paper I'm using to support this information is a systematic review with meta-analysis. Basically, big study of studies where all the data from different papers was pulled together for one individual analysis. This was published in the Journal of Orthopedic and Sports Physical Therapy, and they classified runners into 3 groups across all the papers. There were people who didn't run, people who were recreational runners, and then people who were competitive runners. So recreational runner, we can define that as people who are running for general health and fitness purposes, which is different from competitive runners, are people who seek to make their living from running. Like running is integrally tied to their livelihood. So to put this, in terms of mileage, think a recreational runner might do something like 5 to 30-ish miles per week as a general range, and a competitive runners might be looking more at like 40 to 80 to 100 to 120 for some real psychopaths in terms of miles per week. It is also worth noting that in the paper, non-runners were sedentary. They weren't performing other forms of exercise, which would itself provide a bit of a sort of confounding variable, because other forms of exercise can be beneficial for fighting off osteoarthritis. But the people who were sedentary had a rate of osteoarthritis of about 10.2% in this overall sample. Recreational runners had a 3.5% prevalence, so 3 times less than those who did not run, whereas competitive runners had a 13.3%, so higher than sedentary individuals. So this does not share the same sort of relationship with cycling, where more is just seemingly indefinitely better. If I had to say why that is, running is in general a just more intense form of exercise than cycling is. It's going to demand more recovery than a bout of cycling is going to. And typically, just to sort of put this relationship here, because this is going to, I think, help, most injuries occur when the stimulus applied to the body exceeds the body's capacity to adapt to the stimulus. So if you are providing a sort of stimulus to a body, whether that's running, lifting weights, whatever, and you're progressing that stimulus at the same rate at which your body can adapt to it, then you're going to be fine. You're going to adapt, you're going to get better, and you're certainly not going to get hurt. If that stimulus exceeds your body's ability to adapt to and recover from that stimulus, and that happens for a prolonged period of time, then that's where things like undue degeneration or injury can occur. People who are recreational runners might likely be typically more in line with that dose of stimulus that is more in line with your body's ability to adapt and recover from. Whereas people who are competitive runners, like I said, a lot of the people in this study, there wasn't a sort of uniform definition. The one I gave there is just a functional one to sort of try and reasonably bundle them all together. But a lot of them did have their livelihood attached to running. So you're going to try to push your performance without too much regard of your long-term health per se. Like, it matters more that you win and that you eat tomorrow than if you don't have osteoarthritis 40 years from now. So again, why the running itself, the recreational running, had such a better sort of prevalence of osteoarthritis compared to sedentary individuals who are not running is probably largely due to the general systemic metabolic improvements in health the people were experiencing as a result of running. And then running itself, the impact itself can be health promoting in its own right. Like, there's some specificity to things like the knee and hip, where that impact is going to flush more nutrition into those joints specifically, where you might not get that as much from cycling. When you look at lifting weights, and I don't mean Olympic weightlifting, I believe just standard resistance training, strength training, dumbbells, barbells, stuff like that. I just, put this to be a bit more all-encompassing. This data also comes from the Osteoarthritis Initiative, and it's from the same research group. So they use the same sort of structure to approach the problem. They had the same life stages that was used for cycling. And in this analysis, if you did any strength training at all, you had a 17 to 23% less likelihood of developing osteoarthritis. And those who did the most strength training, which in this paper I don't believe was super high, something like 3 to 4 times per week, was sort of the highest frequency, and that was across all age groups. Those people had a 30 to 31% less prevalence of osteoarthritis. And again, it's good to target the specific muscles around the joint in question. Like, if you have knee osteoarthritis, you probably should do knee strengthening exercises. Same thing for the hip. But the effect is more likely the systemic effect that's occurring from the health improvements from building muscle. Something worth knowing about muscle that most people don't tend to know is that it itself is an endocrine, a hormone organ. So muscle releases something called myokines, which in general are anti-inflammatory molecules. Adipose tissue releases a compound called adipokines, and adipose tissue is body fat. That's the sort of scientific name for it. When you are at a healthy body composition, and I'm defining that as you are at a normal body fat level and you have a good amount of, you then tend to have some of the strongest health outcomes. Pretty much, this is one of the reasons why obesity can be problematic, because that inflammatory signal gets sort of, from the adipokines, gets sort of outsized and amplified. But in that state, it's important to have that low level inflammatory signal from the adipokines, because if you come in contact with, let's say, a bacteria or a virus, that bacteria or virus is coming into a hostile environment. I mean, some inflammation is good, but uncontrolled, unregulated, amplified inflammation for a prolonged period of time, which is really what characterizes obesity. So in obesity, there is excess body fat, typically insufficient muscle mass. I just pulled a Mike Tyson there. And that inflammatory signal greatly overpowers the anti-inflammatory signal. And that can itself contribute to the unproductive environment for each individual joint, resulting in faster degradation of your knee, your hip, and everything of the like. Now, from that same data set, swimming itself tend to reduce risk of hip and knee osteoarthritis. The swimming doesn't have too much to do with your hip and your knee. And even gardening, recreational gardening sustained over a long period of time did produce lower prevalence of osteoarthritis. Now, gardening isn't probably the first form of structured exercise I would recommend for the purpose of eliciting fitness adaptations, but nonetheless, the effect was there. I bring those up to say that it's not the case that any one form of exercise is best. What is going to be best for you is pursuing a multitude of different types of exercise training and fitness adaptations using different forms of exercise. Meaning, maybe you're using cycling for the pure aerobic stimulus. Maybe you're using running for the exposure to impact. Maybe you're using strength training for the purpose of increasing myokine concentration, among everything else that these forms of exercise do. But bottom line is, you shouldn't be singular in your pursuits. You shouldn't pursue just cardio. You shouldn't pursue just strength. You should do everything, ideally with a structured progressive plan over time. And just to sort of note, this isn't just true for osteoarthritis. This is true for diabetes, cardiovascular disease, and everything of the sort. I'll provide some references for that as well down below. But that also just lends the idea that osteoarthritis is a presentation of overall general poor health. At least osteoarthritis setting in sooner than it needs to is a presentation of that. Something else really worth stating, is that it's not like any of these exercises, it's like you do them for 4 weeks and then you're good, you got it. They only give these benefits if you do them for the rest of your life. So if you wouldn't do it for the rest of your life, don't do it for a day. The idea that you can adhere to and sustain a plan long term and it works with your life is significantly more important than how optimal it is for producing fitness adaptations. Doing something is always better than nothing. So this really comes first, and then you optimize for everything else above here. If you are someone who currently has and is dealing with osteoarthritis, the general recommendation that should be made to you is not going to be much different for using exercise to reduce risk of osteoarthritis. The main difference is going to be you structure a lot of your programming considerations with regard to your symptoms. So not everyone with knee osteoarthritis is going to have the same set of symptoms, in terms of pain at the same part of the range of motion, pain at the same part of the knee, etc. So some tailoring to those features should be taken into account, and part of the how you progress should be based off of your symptoms as well. But again, a holistic approach where you're pursuing multiple different types of fitness, just in a way that your knee or your hip or whatever else is going to tolerate well enough, is how you should structure things, like that. So with that said, I'm going to end this video here. I hope you found that somewhat helpful, interesting, or somewhere in between. If you have any questions about anything that I said throughout this video, don't hesitate to comment down below, and I will get back to you as soon as I can. Talk to you soon. Have a great day.